Hello, everybody. Welcome to J3U podcast. I'm your host, John Jewett. With me, co-host Luke Miller. And today we are talking insulin therapy as a prophylactic strategy, but not only prophylactic, but also how we would deploy it as an optimizing agent for your off season or your prep? Question mark. I know we'll leave that like suspense in there because that just came to mind now because before we jumped on, we are like talking about questions that pop up. That I actually had someone ask about that. How would you deploy insulin in a fat loss phase? I'm like, oh, this sounds really like counterintuitive. So we can bring that up.
Yeah, for sure, 100%. I think a good place to start is just kind of mapping out insulin's function, like where are we getting it from, so that we kind of have a basic understanding of the physiology and just the role of the pancreas in response to blood glucose in the blood and via beta cells, and go from there.
Cool. Yeah. So main aspect, or at least insulin, is management of blood glucose levels, and your pancreas contains beta cells where insulin is produced. And so we have a constant flux of glucose elevations and glucose lowering. The counter hormone to insulin is glucagon, which is also produced by the pancreas from the alpha cells, and that will bring blood glucose up. So this is how we have this constant management of blood glucose based around our needs. And that's under normal function. You have a baseline of insulin that's always present. This is our basal level. So it's never devoid of insulin. You're never devoid of glucagon. There's always some levels that are being present. They're just moving around based on what we need to do with managing blood glucose. Glucose is not the only thing that's an insulinogenic. Amino acids are as well. So some amino acids will trigger some insulin response. Fats, not really. So primarily when you do talk about insulin, it is heavily focused around carbohydrate. This is under like normal physiology conditions. Before we get into talking about like a diabetic or someone with some type of metabolic syndrome, we have this basal level, you have a meal present. This meal causes that rise of blood glucose and blood amino acids. And then we have in turn, a rise in blood insulin levels to help with uptake of all this carbohydrate amount, blood glucose, amino acids into tissues. So then what happens when you keep having these high levels of serum insulin levels or blood glucose? We have conditions that arise. Now, did I clearly explain like the role of the pancreas and glucose? Or
yeah, no, I think that's a pretty fair kind of a starting point, because I think that kind of starts the role of like just understanding the management piece and like kind of diving into where we do see resistance over time, especially with body composition starting to go in the wrong direction, food getting to a really high point, things along those lines where we're not getting that same management throughout. And this is where we'll start to introduce the thought process of what insulin are we going to be using. Maybe probably talk about the 4 classes, the main classes, and then go from there. Probably start with what we're primarily using as a prophylactic to start for us, especially since it's like the prophylactic series.
Yeah, I mean, there's a lot more physiology mechanisms that occur around blood glucose management and other like hormones that can be produced, or amino acids that are even produced in managing. That's why we have a lot of diabetic agents that work in different pathways through like GLP-1, sulfurenols. And if you didn't see the prophylactic on metformin, we cover a lot of those other diabetic drugs and those pathways that they work between. But for this context, I don't want to go too far in depth beyond that management, so you have that understanding. Now, so what really leads to this dysfunction in insulin sensitivity, where we have this rise in insulin resistance? And there's some can be an idiopathic genetic component to it, but a lot of times what we see is this. It could likely be a background of inflammation that's really driving a lot of the issues. And this inflammatory process can be leading to more insulin resistance, affecting the amount of insulin receptors are in tissues. Once the even insulin is binding, that pathway to gene transcription. And so this inflammation is probably this root condition that's the issue, and a root condition to a lot of our other problems that we encounter with cardiovascular disease, in being diabetes. And so this causes this high amount of constant insulin. When insulin is no longer being taken up and working at active sites on tissues, constant exposure, high levels of insulin cause even further insulin resistance, cause the beta cells to have to put out more insulin, which is this compounding effect that occurs, and you see rises in blood glucose. So a lot of times when you're already seeing this blood glucose, which normal would be less than 100 milligrams per deciliter, starts rising above that, you're likely probably already had some high serum insulin levels in the background. So if you're not checking like a fasting serum insulin level, then you wouldn't really know. So you might have your labs pulled and you said, oh, I have a normal blood glucose, normal A1C, but you might already having some rise in fasting serum insulin. So we could pull a serum insulin, a fasting blood glucose, and you could get a HOMA IR, which tests your insulin resistance, and you can score that way. So you really want a normal insulin level and a normal serum blood glucose. But if we're seeing blood glucose rise, it may be that you already have a higher serum insulin, maybe not. But usually that's where I see it. It's usually insulin's coming up high in labs, and sometimes glucose is not high. That's typically what I see. And problems around this is that that transition can change carbohydrate and lipid metabolism at the liver and cause a greater transition of body fat gain into visceral adipose tissue, opposed to subcutaneous adipose tissue. And with that transition, that type of tissue produces a lot of adipokines that are inflammatory. So you have more inflammation that occurs. And so this can come from primarily around the PED user. How do you induce this state where you have dyslipidemia, increase in visceral adipose tissue, and insulin resistance, this kind of trifecta, which is metabolic syndrome. So this is a posing risk that we have as PED users, and it's from prolonged calorie surpluses, elevated use of steroids, growth hormone, and then elevated body fat. And through those big picture things is how you're seeing these mechanisms within the body start changing to where we see insulin resistance occurring with constant demand on beta cells. You could maybe see beta cell decline. You see it in type 2 diabetics, and I know that's the critique, is we don't really have that data in bodybuilders that show it, and likely we might not. So we have to look at disease states that kind of resemble what you might see in someone that's pushing an enhanced profile. And so within that, you have some beta cell decline potentially, or just more demand on them. Then there's lots of organ damage that occur through the gluco and lipotoxicity of just high elevated triglycerides and blood glucose. This is exactly what you see when you have like an elevated A1C. Like A1C is your red blood cells with a glycation aspect to them. So there's glucose binding to these red blood cells. That's what you're looking at, glycated hemoglobin. And then like subjectively, what might you feel? Like usually guys are like, you can have a decrease in hunger. You just feel, it's the point where you're like stuffing food down. Pumps in the gym just aren't that great anymore. And probably like you're starting to really notice more body fat gain, or waist is really increasing, but you're not getting the same progress with roundness, fullness, and progression performance wise. That was a lot of rambling on. I went through a lot of stuff.
I just to pull out one piece, right? Like I think even though we may not have the data of like the beta cell decline in function within bodybuilders, right? We can start to look at the research and some of the papers within like the diabetic populations to kind of start to inform decision making, right? It's kind of like that ability to laterally think, right? It's a product of the situation that we're in. So we have to laterally think in comparison, right? And for those of you guys that read the newsletter I wrote on insulin, the paper in there is a really good paper that does show improvements overall from like an early deployment of insulin within that type 2 diabetes population, and improving overall beta cell function, right? And so when we look at managing this over the long term and we consider insulin and prophylactic, we need to maybe start to look at papers like this that show even in the early onset of diabetes for these individuals, we see an improvement in variables and overall function with this insulin deployment.
Yeah, if like I have the paper, I pulled it up, just it's the clinical evidence for the earlier initiation of insulin therapy in type 2 diabetics. That was by Owens. It's in 2013. So if through that paper, you can pull out a lot of other studies reviewing these concepts and why early initiation therapy in diabetics is of benefit, and why we could kind of get into the idea of why you might want to be implementing it early on within bodybuilding, since we're posing a lot of the same risks. And a lot of times I'd changed some of my thoughts on this because I really would utilize Lantus once I saw blood glucose was starting to trend upward. But like I said previously, like once blood glucose is already elevated, likely you already have a pretty high insulin demand. And so early on in an off-season phase might make a lot of sense. And within these, now these are type 2 diabetics, of course, that we look at some of this data from, but when they do have early initiation of a basal insulin, and we'll talk about like what that even means in a second, but when you do have this early initiation, there's anti-inflammatory benefits, antioxidant benefits that are present, which just alone, just PED use in general promotes a lot of inflammation and increase in reactive oxygen species. This decreases those ROS, and it can increase nitric oxide in the endothelial cells. So you have keeps blood vessel elasticity, which is also why when you take insulin, like before you train and guys get a bigger pump, that's kind of the rationale behind it. That's not the rationale why I would use insulin, but just to kind of connect some dots for you.
Yeah.
And I mean, within that too, like you have the improvement of glucose control, and just that alone, when I have that implemented, a lot of guys notice like hunger signaling improves, and there's an improvement in energy as well, just as a baseline, like throughout the day. And then through that deployment too, you could have this maybe preservation of beta cell function. Within that paper, they talked about metabolic memory, and basically it's keeping this level of metabolic function of these beta cells. So when you were to stop insulin therapy, like you were able to compensate on your own for your blood glucose a lot more efficiently than if you were to never use this insulin therapy to begin with.
Yep. I think that's just like case in point of like making sure that we're being proactive. It's kind of like this whole point of this prophylactic series, right? And I think that we can maybe start to lay out the 4 different classes real quick so people can kind of have an understanding of where we're saying like basal insulins, which ones we're mainly talking about.
Yeah. And so this, a basal insulin. So I talked about how you have this baseline of insulin that's always present. And that's what we're talking about when you're using a basal insulin, is the coverage level for what you'd be producing at this baseline. And just to have an idea, to give you some reference, and everyone's going to be a little bit different for what they produce, but for a total daily insulin amount, someone might produce normally 50 to 70 units of insulin. And now this is probably a normal person. Now within a bodybuilder pushing high amounts of food, high body weight, I mean, you could definitely far exceed that. The insulin demand that you're putting on your body is really high. But a basal insulin would be used to replace this basal level. And it's not, the idea of it as a prophylactic is not replacing all of it. It's just some of it. And so the main one that we'll have a lot of action to is Lantus, was an insulin glargine.
Yep.
And it's long acting. It has about I think it's onset of around 1 to 2 hours, and then its action time is around 24 hours. with coverage for the full day, and it doesn't leave really any peaks or troughs. So some insulin that are faster acting could spike insulin levels up higher, and that's more so for mealtime coverage. Well, this one's nice because the risk of hypoglycemia is very, very low.
Yep.
There's been individuals try to like commit suicide with Lantus, and they take like 3 full pins of Lantus and they don't die. Not saying to do that, but what I am saying is that a starting initial replacement of some of your basal insulin is extremely low risk. So some diabetics are taking this prior to bedtime, or they split in the dose AM and PM, and the risk of hypoglycemia is extremely low.
Yep. And I think even in that same class, we can consider Levemir as an option as well, which would be insulin detamir. I can't say the second word, but
yeah. Any doctors, if they listen, please, pharmacists.
please spare us. But Levemir being a good option here too, right? Depending on what you're able to get your hands on.
Do you recall in Levemir the duration of action? I think that one might be the 16 to 18.
Yeah, I think it's around 16 to 18 if I remember. I'm not off the top of my head, no.
And I guess like some people bring up Atlantis, like it does have a little bit higher binding affinity to the IGF-1 receptor.
Yeah.
So a lot of these hormones can bind to other receptor sites, which Atlantis is like a 7 times higher binding affinity than normal the insulin that you're going to produce. However, the unique context within that, like normal IGF-1 binding capacity to the IGF-1 receptor, it's like 100-fold. So the amount that you're going to get out of Lantus binding to the IGF-1 receptor, it's like a fact about it, but it's nothing that I would say is going to be advantageous. Like you're going to grow so much more having this Lantus in place.
Yeah, for sure.
Initiation, like with Lantus for diabetics, is typically around 0.2 IUs per kilogram of body weight. So this would be if you're a 100-kilogram bodybuilder, 220-pound bodybuilder, 20 units is a starting point for a diabetic, someone that with compromised blood glucose management. So I am more conservative in saying, hey, 50% of that would be a starting point for someone that has good glucose control. I'm going to lose my ability to say glucose. So like 0.1 IU per kilogram of body weight. So usually a starting point is around 10 units, which is very conservative and could potentially pose pretty low risk. And this is a prophylactic being utilized. So, with how high would you go with this? I think that's the question lies is that if you're getting to a point where glucose management is so poor, then you need to address other areas. I think we should, before I go down too far down, we should probably cover the other insulins too.
Yeah, for sure. So
how long can you do this insulin for and how much? We'll get to that point, but
yeah, for sure. And I think the other 3 classes are fairly quick because we'll kind of probably touch on the back end here, like the deployment of these, but you'll have fast acting, which is typically going to be your shortest. Is either your Humalogs or your Novalogs, everything along those lines. We're looking at working within around 15 minutes-ish after injection, peaking within 1 to 2 hours. Short acting would be kind of like your Novolent Rs, which would be 30 minutes after injection, about working and peaking within that 2 to 3 hour frame. And then intermediate would be the last one before long acting, which is going to start working around 2 to 4 hours after injection and peaking around 4 to 6. So you're looking at something like an NPH. So those are going to be, go ahead.
No, you weren't done. I'm just jumping in, just chatting.
Yeah. So those are going to be like your main classes. And like, commonly you hear like with insulin, you hear the Humalogs, you hear the Novalogs with people using it around training, which is, there is a case for deployment there. And I think it should be covered here. But when we talk about prophylactic, right, mainly we're going to be discussing the basals. However, the rapids will have uses in some of these like higher caloric states in order to cover some of these large influxes of nutrients, especially around training.
Yeah, I mean, with regard to like bodybuilding, like looking at other coverage aspects and how often that we do eat 5 to 6 meals per day, you're kind of having to cater that around, that's your needs, right? So you have to cater what type of insulin fits around that. And there's a basal amount that should be there present, but also for meal timing and how frequently that we eat, something fast acting would make sense around meals, just like it does in diabetics. Some of the other insulins just have a really profile that just doesn't match well. Like Humulin, Novolin R has an onset, I think it's like within 20 to 30 minutes, and the peak action is 1 to 3 hours, but it can last for like 5 to 8 hours. So it's just a weird timeline considering like when you eat and how much coverage you have. Then the peaks and troughs might be hitting at times when food levels could be getting low in the bloodstream. So it's just really not ideal. I know like in the US, access for Humulin, Novolin R, or Humulin, Novolin N, you can get them over the counter without scripts, but it's just pretty far from ideal from the duration of action standpoint.
Yeah.
So the risk the risk with those of hypoglycemia, I think, is much
are
higher.
high, much higher. And like, this is where, when you hear us talk about like the acute risk being the highest insulin, is like going to that hypoglycemic, right? So, which is where having an understanding of like how long are these going to be staying in are really important, which is where we're probably leaning more towards like the Humalogs and Novalogs when we're using faster acting insulins in order for meal coverage.
Yeah, I mean, so that's the layout of like our insulin deployment. So typically you're going to be looking at Atlantis as a primary strategy. Then if there is a meal that could be very high, that could be something like a Humalog or Novolog. Now within like, I think it gets to timelines now, like when to do this.
Yeah, for sure.
Because we kind of laid out the why behind it. I think knowing the whys behind it is going to give insight to the wins. Because when you're imposing the most stress and blood glucose is the highest, it's going to be moving into an off-season phase, right? And
yeah. So kind of like John said before, like as we're going in the off season, not allowing yourself to wait to where blood glucose is too high, I think is very valuable. So like typically when we consider too high, probably above 100 is the conversation we're having. And I'm probably trying to be a little bit more proactive than that. Once I see it's starting to elevate from where their normal baseline is, which is why the data tracking portion is important. Yeah. This is where
monitor it, right? Fasting.
Yeah. Just monitoring fasted blood glucose. That's when I'm going to start introducing and weaving this into the plan before it becomes a problem, right? And that's kind of where, with the basals, like this would be like a Lantus deployment. Probably the initial deployment is always going to be Lantus, in my opinion.
Yeah, I like people to stay under 90 milligrams per deciliter, and then if they're going beyond that, that's usually when I go ahead and add it in, or usually right in the off-season phase. If now right when we start escalating PDs, I could probably go ahead and introduce it in then too.
Yeah.
And still going off like blood glucose as well, because I'll have data from previous off seasons to kind of look at, and lab data, so I know the guys or females that get into really high food amounts and have higher needs. Those are ones that I probably, hey, right away, I'm going to be introducing this. If someone that I haven't worked with before, we're going to just monitor and go off lab work and see. It's not just like, hey, just throw it in always. But for the most case, like starting at that 0.1 IU per kilogram body weight, moving into that push-up phase is definitely makes a lot of sense to do it around that time.
Yeah. I have a lot of people ask about doing it every day or training day versus non-training. And I think an everyday deployment is fine. And I think that's kind of where just the overall tracking is important, like taking one post a training day, taking one post a non-training day. It's kind of how I have my clients set up. But I do think just an initial deployment could just be training days. But I think across the board would be fair too.
Yeah, no, I agree there. It just keeps it consistent and adherence. It makes it easy to remember, just part of routine. A lot of times we're not seeing such a vast calorie difference day to day, and usually output is a lot lower to compensate for that on your lower calorie days. So the surplus is still there.
Yeah.
So the insulin need would still be there. Like some questions around initiating it too. It's like I've heard it. People ask like, do you need to be using growth hormone to use insulin? And my
Good
answer to
question.
that is just consider these as separate drugs. There are aspects where they have some synergies together with growth hormone, but basically the own insulin that you produce meets that need. So presenting insulin is just when you're getting compromised in your own production of insulin. Um, again, why we're deploying insulin, not to make some greater advantage by adding it in for growth hormone use. Now, there is this advantage to adding in for other reasons of prophylactic that we're talking about. Other question I got is, will insulin therapy cause your pancreas to shut down? I think the thought process is like when you're taking testosterone, right? You shut down your natural
HPA.
would you shut down your natural production of insulin and have this hard time getting it back? And it's quite the opposite. This doesn't work the same way. So you would take insulin, you wouldn't be producing as much endogenously. However, when you stop, you actually, since you have this kind of pancreatic rest that occurs, you actually still would be really efficient in producing your own insulin. They see that in diabetics as well too.
Yeah, this is where you see that metabolic compensation in that paper if you guys go read it. So it's a really good paper.
And then another one would be, using insulin cause insulin resistance to worsen? So people think if you take insulin, I'm going to get insulin resistant.
Yeah.
And not necessarily would be my answer to that. Insulin doesn't cause insulin resistance per se. Yep. Being a state of high chronic levels of insulin with inflammation can worsen insulin resistance. Yeah. Insulin itself might not, though. It's more of this chronic state of being elevated with high food, GH, and that high system inflammation oxidation. So we use insulin therapy to treat diabetics. So if the drug caused diabetes, we wouldn't be using it. So think of it in that sense, and that would make a lot more sense out of it, right?
Oh man,
giving insulin and it causes diabetes.
It's like, oh man, it's so backwards.
Treatment plan.
A very anecdotal question I get is about like gut growth, like overall midsection growing with insulin usage. As far as like from an anecdotal perspective, seeing like these larger bodybuilders getting like bigger guts over time. What I would say from an anecdotal experience, that's probably more a problem from pushing food chronically, bad digestion, not managing that digestion in the off season, and doing things to kind of wreck yourself. Because if you go back to some of the podcasts where we've talked about meals off plan, we've talked about how that can reduce the response to food for 2, 3, 4 days when we talk about like the insulin response to food. And so this is where we start to get that like GI dysregulation, that more than likely the root cause of some of this rather than just insulin itself.
Yeah, like the waist size thing, it's kind of multifactorial. Like we were just talking about, the problems we present as bodybuilders is kind of this metabolic syndrome and insulin resistance, dyslipidemia, increase of fat deposition around organs, the visceral fat increase. So it's like, how is someone shredded and still has a distended gut? Yeah, they have a lot of visceral fat around organs. What causes a lot of visceral fat gain? Exactly what we're talking about, insulin resistance. So will insulin cause you to gain more fat around the midsection? No, insulin resistance will. And so if you're just trying to manage blood glucose with insulin and you keep pushing food, you keep pushing drugs, you're not fixing the problem that's still in the background. Yes, you might have blood glucose, that's okay, but you still have insulin resistance. You just have a higher need now for insulin requirements. So that's where the problem's there. So yes, have some management of utilizing insulin as a prophylactic, but we don't want to get to a phase where you're having to use it as a treatment for a disease state.
100%. I think that brings us to a quick discussion of fast acting deployment. Just like
Wait,
going
I think I have.
another
Yeah,
question.
I got another thing that came to mind on on insulin. So we talked about like when to use it. I guess how long would
Ah,
that we just talked about like when it's going too far. Well, there is a point of going too far. Usually like I don't take it up past that, usually 20 units
yeah,
per
no, me
day
neither.
usage. I think if we're seeing like you're not able to control blood glucose and it's still elevating beyond, usually around that time point, there's a lot of things happening too. That's usually when hunger signaling is getting really poor. People feel like they're pushing food down. You might have just more of this like kind of generalized swelling of inflammation that's occurring, and also we're seeing kind of that poor partitioning happen. Guys are just getting softer, and we're not seeing as much out of the gym either. And so that's usually the point of like, hey, let's pull it all back. Let's decrease food, decrease training volume, we're decreasing drug load, and with all that, your insulin needs are going to be going down. Now, moving into that initially, you could keep some insulin present, but then you could probably remove it because you overall decreased all the drivers that are increasing insulin needs. And so that's when how long you would I use insulin for? Well, it's as long as you're able to tolerate the increases in stress of the off season. But once you're seeing that detriment occur, it's time to pull back and then kind of rinse and repeat that process. Don't just keep pushing because that's when you're going to run into those issues with getting real suboptimal with health markers and body composition markers.
100%. Yeah, I would agree with all of that because that's like I'm not taking it above that either, and I'm definitely pulling them before that need. So, fast acting, yeah,
Acting. Yeah.
Humalogs, no vlogs, some bodybuilders' favorite usage, right? So, typically we see this used around training windows. So, large influx of caloric intake around training. So, we'll see a larger pre-workout meal, pretty sizable intra-workout carbohydrate usage, and then post-workout we'll also see usage with like larger post-workout meals, especially for like your larger bodybuilders. And this is more just allowing us to return these postprandial blood glucose values to be ready for this influx of food again, right? So across training, like using this pre-workout will be a very big benefit for overall nutrient partitioning, especially within training. We had talked about kind of like the vessel expansion from insulin use. But then on the back end, when we look at it, a lot of where my usage is going to be is being considered using post-training where we have these large influx of calories and we need the response to be coming back down for the next meals, especially for people who are eating 2 and 3 meals at night before they're going to bed after training.
Yeah, I think once you're getting to this point where you're having some amount of Atlantis present, I mean, arguably you could have some amount of Humalog present around. Maybe for us, usually we have a lot of food positioned around training, and people argue because you're getting kind of really into this point of like, does nutrient timing matter, and why not just have your carbs evenly spread throughout the day? And that's an argument that could be made. Um, However, I just still have a preference of moving a lot of food around training as from a digestive aspect, and also because I have this pretty long, that's probably my longest duration where I'm not actually able to sit down and eat a meal. So I put a lot of food around that because of that point. Also, when food's getting high enough, you can just drink a lot of calories while you train. It's just another spot to be able to keep consuming food. Then that post workout window, we could put more food around there. Usually you can tolerate quite a bit more, and we could go with some even faster digesting carbohydrates because the need's already risen up so much. So you get to a point when food's high, it's like, how can I just fit in more? And there's just a lot of advantages around that training window from time duration and also nutrient uptake. So we have a lot positioned around there. You could offset some of those demands put on beta cells by using a fast acting. Um, and I see whether you want to use it pre or post, You kind of look at the duration of action. It's relatively fairly quick with a Humalog and lasts for, I think it's 4 to 5 hours.
Yeah.
So if you were to say you were to use it pre-workout, it would probably span that meal through training and trickle into the post-workout period. If you were to use it post-workout, same thing needs to be in mind that within this probably I think it's 3 to 5 hours if that range is right. Does that sound?
Sounds about peaks around 1 to 2. So it's going to be around the 3 to 5 is going to be staying active.
I can't remember if it's 3 to 5 or 4 to 5, but either way, depending on where you have a lot of food position would probably be where I'd want to use it.
Yeah.
Do you need to use pre and post? No, I don't think so necessarily, because it has this window that it operates within. If you're getting to where you have that much insulin demand, again, it's go back to reevaluating, like, is it time to pull back? But also I think it's the time of day you train too, because if you have someone that's maybe they train and they only have one meal before going to bed, just be considerate of that, because adding insulin, that insulin's probably going to keep working way past that meal. Risk of hypoglycemia is a lot higher. So that that would be more in favor of doing it pre-workout. If you had someone that said they had a lot of meals post-training, then it might make more sense to have that with their post-workout period. Starting points with Humalog, Novolog for diabetics, sometimes they'll go around with 1 IU per 10 gram of carbohydrate. Again, these are insulin resistant individuals, so you have to be considerate of that. The issue with pre-workout is a lot of times you're testing blood glucose after you're taking this, and no one's testing blood glucose during training. So, and rarely people are testing it post-workout. And so I still am conservative with it and go 50% of that. So it would be 1 IU per 20 grams of carbohydrates. So if I'm eating 100 grams of carbohydrate, pre-workout, 5 units of Humalog would be a starting point. And honestly, usually I start with 3 on people.
I was about to say the same thing. I was about to say the same thing.
Yeah, I'll usually start kind of like that's some like framework of like structure around grams of carbs, but 3 IUs, it could be a starting point. Then I might move it up from there.
Yep, 100%. I think that's a fairly good coverage of like main uses for insulin and just kind of where we're deploying it and some of the considerations around why we're considering it a prophylactic at this point.
I'm going to try to think of some other questions that come to mind. I mean, with in using insulin around training, like just be mindful of what hypoglycemia could feel like, because that is the main danger. I would always have on hand some type of fast, either it's like candy, or like you can get like glucose cubes, or even something simple like a Rice Krispie treat or something like that while you're training. But just be aware, like if you have cold sweats, you feel lightheaded, hunger, irritability, dizziness, like those could all be signs of hypoglycemia. Like I would take like a glucometer along with you just to make sure. I know those describing those symptoms, it's like, man, I already feel like that on leg days. Fair enough. Like, but that's why you'd want to have those things already on hand, just in case.
We didn't cover prep deployment.
Oh yeah. About that. So I've seen some protocols using insulin, like 1 to 2 IUs fasting to bring down blood glucose further, with the rationale that being with a low blood glucose level, you would have increased fatty acid oxidation during your cardio. And I think give it that amount of insulin is fairly low. I think still, even in prep, now this is anecdotally, I have people go hypoglycemic without taking any insulin, and even between meals, and I've even done it. And the sensitivity to it is so high already. I think it's getting into looking a little bit simple at how more complicated body fat metabolism is. And that's, big picture, if you're in a calorie deficit, like you're going to be losing body fat, and don't just think that at this moment of time that you have to, you're only going to be burning body fat, but the rest of the day you won't be. It still comes down to the big picture. And I think there's just a lot of other tools if you're to be deploying in a fasted state to utilize for enhancing fatty acid metabolism with the growth hormone, clen, caffeine, or any of these other aspects without really posing some danger with insulin. And just you already should be waking up in a state of low blood glucose if you've been on prep. And so I don't see a further advantage to it.
Yep. Same. I was gonna say you're kind of playing with fire there, especially with like I've just had too many clients go hypo during a prep to really warrant that usage. Now I've had a couple situations where I'll keep a basal in the first couple of weeks just because they're kind of starting a prep a little bit earlier, and they're coming from a little bit of a higher food chronic state, like end of all season. And so that transition period, keep it in just for management until we start getting into deeper deficits. But that's about it for me.
Yeah, I know. It's like, what about refeed days? Like, do you use insulin in those? I think if once you're to a point where you could benefit from a higher carbohydrate refeed day, you've already probably been a pretty low, chronically low insulin state. So you're going to be pretty insulin sensitive. Like your ability to produce insulin in that state is going to be completely sufficient. So are you going to have this added advantage to using exogenous insulin at that point? And say no, because on an insulin per insulin basis, so is your exogenous insulin going to have a greater advantage than your own production of insulin? And it arguably no. And then the other aspect of that, like, well, will you have the same ability to produce insulin in that state? And arguably, yes, you have the ability to produce sufficient amount of insulin. When you don't is more so in an off-season state when food is extremely high chronically. This is just an acute moment of higher insulin demand. Now, could you have some type of little small basal amount that you put in? Yes, but I could see like there's no rationale for it. Like there's not a further advantage of it because you won't be chronically in that elevated state.
Yeah, agreed.
The other part would be on what about carbing up on pre-show? I've seen insulin deployed in those settings.
Loading situations, yeah. I don't think it's necessary. I think if you're ready, you're at body fat levels, dear God, body fat levels that are so low and you've been riding that low insulin state so long, it's hard for me to warrant it, man. You're just gonna be so sensitive to food that it's. I mean, I've had people loading go hypo after a meal just for that postprandial drop.
Yeah, the first time I used insulin was the 2015 NPC USAs.
Yeah,
I was fucking depleted. Like I had to really like make middleweights was like, oh man, it looked hectic, man. But anyway, I was going to use insulin because like, man, you got to load hard. And when I did use it, if I recall, I think there was like 5 units of Humalog with a meal. I can't remember how much carbohydrate it was, but shortly after, it was like 2 hours after the meal, I started getting all those symptoms of being hypoglycemic and needed to add in more food. And so there was an issue with that. However, it just is saying like, you're already so insulin sensitive in that moment. Like your ability to produce insulin is going to be, for one, your sensitivity to insulin is extremely high. So you're not going to have to produce a lot of it. And your ability to produce that amount is also going to be very, very sufficient. Because even when I like post show, when I had my labs done, my like fasting serum insulin was like at a 2, which is like barely any insulin need. Like off season, normally I might cruise like 6 to 8. If you're over 10, that's kind of the issue. Like if you're over 20, you're like way like diabetics. This is a real problem. But in that state, like you're insulin sensitive and and your ability to produce insulin is very sufficient. Now, if you're adding that insulin in and you're going hypo, now you're having to add in more food. So now you're having to feed the insulin. And if you're in a loading situation, that easily could get to this point where you're like, oops, I ate too much food. What happens then? You're kind of like spilling over. And if you're not absolutely shredded to the bone, that could be, I think that could be an issue.
Yep.
It just throws a lot of variables that might take you down a path of having to make some corrections that don't need to be there. And I'm yet to see someone that has like such a high carbohydrate demand carving up that they even justify having insulin. I know there's some like protocols out there that do some really aggressive loads. That's just not my style to do it because I think there's too much rolling of the dice within that. It's like load up till you spill way over, then you got to clean it up. And the digestive demand that's on that is problematic. And then there's just this variability of like, are you going to time that amount of like cleaning up and getting dropping some of that water off in time? So I prefer all the like that goes back to our peak week podcast that we did. But yeah, in summary, around that peak week period, I just don't see the need for it. I know there's protocols out there, but again, with how I run things, I like a little bit more predictability in the look.
100%. Well, I think that covers most of the questions. I'm trying to think if there's any other questions that I get around insulin usage.
Females, I mentioned a male-female situation, but all this same conversation applies the same to females. There's no difference around that. If you're posing the same things that you would as a male, insulin can be deployed within that same scenario.
Yep, 100%. Nothing else that comes to mind for me.
If you are a YouTube listener, you're welcome to leave comments and questions below that maybe Luke and I did not answer or things that didn't come to mind. We'd be happy to answer those for you.
Yeah.
If you listen to on other media streams, maybe go to YouTube and ask us a question. Can watch us too. But anyway, that will cover it, guys. We'll talk to you next time.